My dear student, in the last class I talked about chest X-ray PA view, and today's my class about regarding on chest X-ray AP view. So the chest X-ray AP view is always optional. Okay, usually when PA is not possible, only that time at that moment we will go for AP view, supine AP view. In that AP erect also is there, is similar to PA, but AP erect will be not taken because that's instead of AP erect we can go for PA erect. That's why AP erect will take we will never take. So AP supine, sometime any suspected trauma, patient unable to stand, unconscious patient, paralysis patient, any neurological disorder, those kind of suspected is there, means we will go with the chest X-ray AP view. Then particularly when we need a frequent X-rays in ICU, any isolated ward, it means any portable radiography, that moment we will take a AP supine. So but compared to the AP and PA, that's I added in a few slides later. That is, I already told that is particularly is taken to just to make out what are the changes in the lung, if anything ICU patient or anything, to see that pneumonia, any bronchial disease, any changes in the after post-operative, so any fracture in the rib, scapula, at that moment and all, we going to see this chest X-ray. That's what I told, trauma patient, if the trauma anything is there. So usually if you take a chest X-ray AP view, heart and all measurement, heart size in the sense cardiothoracic ratio and all, it is not possible to take because the heart is so much distance from the cassette, so there will be a magnification. We'll go with the patient positioning. The patient comes as the same procedure how I explained in chest X-ray PA view. Identify the patient, all those things, change in the dress, pre-procedure, all those things. What you will do next step, you will ask the patient to lie down in supine positioning. Both the arm will be kept aside in the both side of the patient to avoid the overlap on their chest. The mid sagittal line will be perpendicular to the table. Mid coronal line will be parallel to the table. Okay, mid see, there is a marker here. I am not able to get the marker. I think next class I'll explain you people how mid sagittal should be perpendicular, how the coronal should be perpendicular. Okay, yeah. Okay, now yeah, see, now the patient is lying down here. You can make out patient is lying down in supine positioning. The mid sagittal line which is dividing right and left of the patient. So now this is the table, example, this is the table. Okay, this is the table. If the, now say example, this is the patient is lying down like this, so this is the mid sagittal line, okay, which is dividing the right and the left. Okay, now if this line is perpendicular to the table, means we call mid sagittal line should be perpendicular. Now sometime some other I also mentioned, mid coronal plane or mid axillary plane should be parallel. Parallel means, now this is the mid coronal plane. Okay, this is the coronal and this is the sagittal. So this is the coronal plane. So when coronal plane parallel to the cassette, parallel to the both the side, it should be equidistant, parallel to the cassette, we call as a parallel. So here when the patient is lying down, always should mention that mid sagittal line will be perpendicular or mid coronal line will be parallel. Any one sentence is enough, no need to write both. So after that, what next steps? Then patient positioning over, part positioning over. Patient positioning means patient will lie down in supine positioning, ask the patient both hands be kept aside. Then part positioning, mid sagittal plane will be perpendicular. Okay. Then cassette will be placed, the upper border of the cassette. You can see here, this is the digital radiography bucky. So upper border, see, this is the upper border of the cassette, this is the lower border of the cassette. This upper border of the cassette should be, see, this is usually at the shoulder level, it should be 2 centimeter above the shoulder level, 2 centimeter above the shoulder level. So that cassette should be in this place. Okay. Then whatever the part below includes, that should be included. So always 2 centimeter above the sternal notch also you can mention should be above, so that if you may kept that upper border of the cassette means you will able to include whole length of the thorax. Then what is the next point? This is all the explanation of the patient, patient positioning, what I explained you in the image itself. So what are the instruction, what all things you need to do? Now after lying down supine positioning, after placing the cassette, next is you will give an instruction to the patient to hold a deep breath inside when you are going to expose. And where is the centering ray? 7th thoracic vertebra, approximately 7 centimeter below the jugular notch. Okay, almost it comes there only nearly around the mid of the sternum. So that's the midpoint of the centering ray. So collimation and all should be all properly collimated, so that unnecessary exposure you should be avoided. In a previous class also I explained you. The same time, the lower part you can see here, this is the lid apron, lid cover. Lower part of the abdomen should be covered, so that sometime what will happen, this all primary rays, it will come here, and sometimes some of the scattered low primary rays also might reach in this, because always X-rays from the X-ray tube which is coming, it will be in a fan shape. So always, that's the reason we will always, here also you can see this is where collimated, well collimated, so to make a exposure only this much area. Okay, so avoid that unnecessary exposure to this, you should be collimated. Then orientation, same thing what I said last class, portrait or landscape you can keep. Detector size, same thing, 35 into 43 centimeter or 14 into 17 inches. Usually we will mention 17 into 14 inches or cassette size. And exposure factors is better to use high kVp technique. So sometime if it is suspected of fracture, thoracic or anything fracture, means high kVp technique you don't use, because we need to get the good contrast of the bone and the soft tissue. In high kVp technique, usually bone and or penetration will be, you can't see very good quality of the image of the bone. That's the reason. If it is a suspected fracture or rib fracture or anything, means we can give factors around 50 to 60 kVp, around 10 to 15 ms can be given. SID, sorry, here is mentioned 180 centimeter. It's not 180 centimeter, it is 100 centimeter. That's what, 4 feet. Then grid, yes, always is better to use the grid. You can see this is the two comparison between the two radiography. So you please ignore that below whatever the content is written. You can see this is how the image of the patient, you can make out how it will be changed when you take radiography. See here some of the example you can I mentioned in the next slide, I'll explain it. So here you can see heart size. This is the actual heart size of the patient, but here is magnified. It is not patient have any problem. It's a problem with the AP view he taken. So kindly neglect these all the points what is written. So what is the difference between two radiography, PA view and AP view? When PA view, if you take patient in standing or sitting positioning, where in AP view, so patient will be in a supine positioning. In PA view, no overlapping of scapula on lung field. It is because we ask the patient to fold the arm and all, we will take it. No, that's why. But in AP view, scapula will be overlapped because we cannot avoid that overlapping on the lung field. Clavicle not foreshortened, where in PA view, where in AP view, clavicle will be foreshortened. You can see here. See, this is the length of the clavicle. This is actually the clavicle is actually not exact size, but whatever the size you see here in the AP view, this is the actual size, because patient will be lying in supine. It is patient arm, it is not tilted. When it's tilted, there will be foreshortened. So ribs course obliquely in PA view, wherein AP view ribs will be in a horizontal course. See here you can see in the previous class I told you, see this ribs is coming originating from the thoracic vertebra, then it's coming down and it's going downly, it's oblique like this. Where in AP view you can see horizontal almost, it will be like this. The origin part. Later anyway it does get it is crossed, covered with the anterior part. That's the reason. Then no cardiac magnification in the PA view. In AP, cardiac magnification will be there. Fundic air bubble will be seen in the posterior PA view, and fundic air bubble not seen in the AP view. I think in the last class I told you in the first basic class. You can see here this is a dome of diaphragm. This is the dome of diaphragm. So this is the dome of the diaphragm, where here you can see this is the fundic air. The air is inside the stomach. So when patient is standing, that air will come and stand in the upside. That's why we are able to see. But in in AP, definitely there will be air. What will happen? It will not come and stay in one place. It will be distributed all over the stomach. So the density will reduce. That's why we are not able to see. This is the difference between the PA and AP view. So kindly go through this. This topic also is included in first sessional exam. As I told in a PA, the same thing in AP also. Most of the parts are similar, but the difference between PA and AP is always better to have a look, because definitely 100% I'll assure you that that question will come for the exam. So remaining, if anything doubt, anything is there, means kindly go through the Clark positioning or Merrill surplus. If it is those book not available, please let me know, or else it is available in the Google. You can download the PDF. And if anything doubt or anything is there, please you can contact me, or you can ask me through the my number. You can WhatsApp me if you have any doubt. Okay, thank you.